I think from the public standpoint, I'll say yes. I'm old enough to remember standing in line at the bank, waiting to take money out and waiting to pay my bills with a teller and stamp, right? Now I just do it in this ATM. Now I do it at home on my phone, right? Like, how crazy is that? Who wants to go back to that old method? So I think if you ask the patients and they would say, oh, seriously, I got to come to your office.
This is the Public Health Insight Podcast. Before we move on, it is important to note that the views expressed in this podcast are our own and do not represent any of the organizations we work for or are affiliated with.
In the previous episode, Gordon and LaShawn spoke with Dr. Keith Thompson, Chief Medical Officer of iTelemed Canada, about virtual healthcare technologies and how the pandemic has influenced healthcare policy and the uptake of telemedicine services. In the second part of the discussion, Dr. Thompson remains with us to discuss the importance of addressing the digital determinants of health and the ways in which telehealth can be leveraged to reach marginalized and isolated populations. This is where they left off.
And speaking of barriers, according to the Canadian Radio, Television and Telecommunications Commission, we know that almost 88% of Canadians have access to high-speed broadband internet connection. So that's really good. However, compared to just 45% of rural communities. So this brings up concerns and questions around the concern of the digital divide that you spoke on when we just started this conversation, the broader digital determinants of health, if you will, and whether these virtual health technologies can actually be used to deliver care without widening the disparities even further. So I'm just going to ask you, it's a mouthful there, but I'll put it out to you. So we talked about a lot of problems that virtual care can help to solve, but what are some problems that it does not help to solve as easily?
Yeah, and listen, you hit the sweet spot on this because we can run a line to the community and we can improve connectivity. But, there are lots of studies that would say access to care, whether it's virtual or face-to-face, is only 25, and some studies as low as 10% in the US, determining healthy outcomes. There you're getting into what are the social determinants. Why is there poor health? Why? And it's poverty, or it's environmental, it's social supports, it's education, it's literacy. There's so many other things. It's culture, it's gender, it's genetics. I'm looking at the list ahead of me. There's like 12 items, right? The classic social determinants. You know them better than I. But digital and virtual may not address all of those. Or access to care. It's a platform to get into the community to provide care, but it's got to go beyond that. I think it is the challenge. And, there are some regions that are doing a wonderful job at that. And some other countries, actually, the way they've kind of cracked code on this is looking and learning that the physician need not be Dr. Do-It-All or the primary go-to. So they've leveraged health technicians. And in India, there's a program where with a knapsack and a carry case for ultrasound and weigh scale and a little digital device can go into these communities and using the cell network and do those encounters with patients and really provide a lot of care that can decant off, right, and not necessarily need physician engagement. So I think that's the first part. Second part is look at a program by, and again, no financial conflict of interest, but Philips has done some wonderful work around access to care or community life center. And so it means going to the community and just like any other innovation and deciding what are your needs, customer survey. And what we need is kind of microeconomies around this. So Philips went in recognizing that clean water and power was the first thing. Set up a solar panel, set up clean water. Theirs becomes your health station. But that station, when it's not serving health needs, in the evening, there's a light for the soccer field. It's a center where people can come and chat and gather, and it's a gathering place that's safe, right? And they know that, community services, and maybe it's a social dinner, or it's a party or whatever, right? Or it's an educational experience. A group of women get together, maybe there's a microeconomy that's evolved because they need power to run, whatever device. So I think we think outside the box that healthcare is not the sole solution, but what connections we bring into those communities, how we can build around that really is, I think, what we need to start to think about.
Yeah, and when we're talking about the social determinants of health, which is what all this is encompassing, making sure that we touch on those social factors that affect health, there's so many. And one of the things that was striking to me is that talking about the lack of interoperability or connectivity with EMR or electronic medical records, e-booking, and lab diagnosis. So there seems to be a lack of collection with these social determinants of health data within these databases itself. And so what are your thoughts on that?
Yeah.
What's going on?
I would reference Dr. Dan Pepe, who's a great lead here in our community on the digital and the Ontario Health Team Network. And I said, Dan, I'm a convert to coding, right? And he said, Keith, I've learned not to boil the ocean. Basically, we got to find the patients that are needed and the codes. And what's interesting is, what are the ICD? I hate to say we're still using ICD-9 because that's what the OHIP codes require. So I think it stands for International Disease
Classification of Disease.
Okay. Thank you. There you go. So ICD-9, there's ICD-10, and are we to an ICD-11 yet? Or but much more descriptive. But bottom line, as Dan would say, let's not boil the ocean. Let's just get good coding practices within primary care. And what are the codes for social determinants? Mm-hmm. And is that going to be seen as acceptable or intrusive? So if I code you for opiate use disorder or extreme poverty, right, is that marginalizing you further within your medical records? So when I go to a specialist and the first thing that pops up, right, do I necessarily want to share that? I mean, these are some of the ethical considerations around it, but in a pure population health, I agree, we don't know. And that's probably assuming as well there are many patients out there that aren't even connected at all, right? They have no, like a lot of these surveys, I'm sure, are upon people who have primary care. They're already attached, but what about the ones that aren't, right? And what is their need, certainly, around healthcare, let alone, I'm sure healthcare may not be the first thing on their mind. Their first thing may be thinking about where's the next meal coming from. So,
oh boy.
Yeah.
And we've had episodes on the pros and cons, if you will, about collecting race and ethnic based data. And it's not clear cut either way that who owns the data. If it falls into the wrong hands, you can marginalize populations even further, social exclusion. So there has to be a framework, even from a policy level, governing how this data can be used.
Well, I was just going to say, like a code for many people living within one small dwelling, right? Might be a code that we recognize for future pandemics, regardless of social status or income or any of that. I'm 5 people in one household, right? That's a risk. And we see, again, how hard it was hit in racialized communities for COVID. And part of the reason for that was, you're right, many people, into one small apartment to eke out an existence, but high risk rate for transmission of the disease. Not to mention that they can't afford to take sick time. And we can go on to that discussion as well.
So to dig further on that though, so because of physicians and healthcare providers' scope of practice, for example, if someone's in a precarious housing situation, it's essentially out of a physician's scope to maybe necessarily directly be involved in getting that individual to a better situation. Do you think that's maybe why there's a disconnect with that information being collected in terms of EMR?
Yeah, I mean, there are some wonderful tools that were created, right? The poverty screening tool, and we're really being encouraged, right, to ask and see. There may be some programs that people are not aware of, that they're eligible for ODSP or they're eligible for CPP or whatever, and we can help them with that. We might not all know all the ins and outs of the application, but we certainly can steer them in the right way. So maybe, again, having that relationship and part of a thorough history in primary care, I think we do a pretty good job of understanding where our patients come from or understanding their story, right? I know them in detail. That's the danger with virtual, is that it's episodic. And maybe they have access to a physician, but do I really understand on a 1 or 2 time visit for, say, a drug refill or medication refill? Do I know their whole history and have time to delve into it, right? And so this is, I think, where the challenge lies, is getting everyone connected in some manner to primary care. Face-to-face or virtual, I think, is beside the point. Getting them into primary care. And once that is established and that relationship is longitudinal, then the value add may be if they want to talk to me by telephone for certain things, that's okay, right? So I think, the issue that the technology can't solve is getting people outside the lifeboat still floating in the water into a primary care raft, right? That's a challenge.
For sure. And another thing that brings to mind for me is the idea of, traditionally these physicians are used to having these physical one-on-one interactions in person. Now, there's been that transition to that online environment, and then there's something called website manner. So how does that kind of play into this?
Yeah, so the website manner, I love that term. I think it was coined during the CMA, their virtual care task force, or it may have come from the US, I think, the root of it. And it really just centers around patient-centered care, right? So as I'm talking to you, I'm looking at the camera, I'm engaged. I'm not doing this. What was your heart rate the other day? Right? Just, so the patient knows you're there and you're engaged, and they can sense that. And whether, I think video is a value add, so certainly it's another layer to that engagement that for sure it helps. And certain things like privacy, right? And it's amazing. I think you've heard on other podcasts of patients like, are you able to? Yeah, I'm at the Tim Hortons doc. It's okay. Go ahead. Right? Yeah. You sure you're okay to talk now about this problem in line? Yeah. Right. Some patients don't mind. Others, they'll remind, just a sec, I got to step out. There was an interesting comment I remember by one employer. And this again pre-COVID, where they were looking to provide virtual care for their employees to save them having simple stuff. They need a drug refill, whatever, to leave time, leave work. Hey, we'll provide that service. We have physicians on call who'll provide your needs. And they dedicated a separate room, and it was private and quiet. But it was interesting that as soon as you went to the room, you're like, why is John going to the room? Who's he talking to? What? Hey, what's wrong, John? Right? And they knew that was the doctor's room. Right? So privacy was kind of shot. So website manner, I think, though, just entails the relationship with the patient, right? Just being on best behavior, not wearing your Ron John shirt, although maybe it's okay. It's all good.
So just to bring things back full circle, we know you had mentioned you were part of this working group with the IEEESA, working to recommend standards in terms of increasing digital health access for rural and remote communities. So what do those standards look like, and do any of them involve addressing these digital determinants of health that we spoke about?
Yeah, they certainly, they're hoping to go that way. So very early in this working group, I just learned this past week one of the official standards. So, and to define this working group, we're proposing ideas and standards. The first one's going to be definitions, the lexicon, right? The verbiage of virtual care. We'll write a document and we'll elevate it, and if it's accepted to standards, hey, great. One of the standards already being worked on, P2795. Which is looking to understand regionally dedicated lines or pathways for healthcare. And what I learned from that group is what's been interesting. In some of the areas, the capacity, the bandwidth is great, but because everyone's at home on Netflix, it's chewing up bandwidth. So when they need it for the local hospital, right, to hook into the ICU, or they need data, right, it's glitching the Wi-Fi, at home, it kind of got 5 people on their device and the Wi-Fi is struggling. Same sort of problem with healthcare. So that's one issue really that they're kind of looking at first, is that dedicated line. And also they've done some early mapping. I think you guys love GIS maps, right? Take population health and put it on a map. So they've done healthcare access, and they have done connectivity, and I'm not sure the defining, I think it's just cell phone connectivity at this point, and just plot it out. And of course you can see, right, the hot regions being the urban, and kind of thins out and opaque as you get into those rural. And so trying to figure out, how do we solve that issue in connectivity? And is it cell phone lines? Is it satellite connectivity? I mean, is Elon Musk going to save us all when the issue of connectivity? I don't know. Right. But just on that note, as you get to the very northern regions of Canada, the SAT doesn't work. And there's maybe only 100 to 200,000 people within that region, mostly indigenous. And nobody cares about that market because it's not big enough. There's no sustainable business model, right? And so there again, the issues in marginalization and remote regions is how do you sustain, what is the business model around this? And so we're looking at very early on how we might be able to connect the reduced greenhouse gas emissions as a value add, and can we create some sort of social or developmental impact bond that would sustain that, make that a model that goes beyond just the government throwing money at it or a philanthropic or NGO support, because the problem is that eventually the plug gets pulled on those revenues and you're done, right? So how might you build a sustaining business model or economy around that? And I think if there's a way to connect green, reduce gas emissions, because think about virtual, definitely less travel, especially northern regions. Oh my gosh, to fly somebody, south to connect or transport them, plus the family having to come, and the indirect costs of getting a motel room to stay with mom or dad or their loved one while they're in hospital. If you add that all up, it's a substantial savings in terms of reduced greenhouse gas. How you structure it in the social impact bond is extremely challenging. These bonds are complicated. They take tons of time. Zenikayat is, I will call her my hero right now because she understands this very well. And she's done a lot of work on this. And in our last session, we were chatting and Zaina said, Keith, the work that goes into creating these bonds really is almost unnecessary. If a government agency is the payer, and you want to just go directly to a provider and say, here's the outcome we're offering or we'll pay for, and if you can provide that outcome, here's how we'll fund it. And so anyways, so IEEE, believe it or not, is looking at this potentially, but very, very early on. Right now, it's all about the connectivity and how to get it equitable across regions.
All right. So those are very interesting points. I wasn't aware of the climate change angle. I didn't really conceptualize it that way. So that's a very, in terms of stating the value add of virtual care, I think that's a very critical component. So I want to talk to you about, in terms of a final parting thoughts in terms of this conversation. Is it safe to say that virtual care is here to stay in our post-pandemic recovery? Is the future somewhere in between, like you mentioned, where it's like a hybrid of in-person and virtual care deliveries? Like, what are your thoughts on that?
Yeah. I think from the public standpoint, I'll say yes. I'm old enough to remember standing in line at the bank, waiting to take money out and waiting to pay my bills with a teller and stamp, right? Now I just do it in this ATM. Now I do it at home on my phone, right? Like, how crazy is that? Who wants to go back to that old method? So I think if you ask the patients and they would say, oh, seriously, I got to come to your office to talk about my lab result? No way. I think the public pressure will be such that this has to, in some manner or form, be sustained going forward. One of the projects Dr. Bridget Ryan's doing is that understanding that hybrid model. So a combination of face-to-face and virtual. And we already have an idea of what things we can do really well virtually. Again, in the context of an ongoing sustained relationship with the patient. And that's where the challenge comes for those patients outside, those individuals outside of that tent or outside of primary care. How do we make this service equitable? And I think, my final thought on this really is going to be that it's more than just a technology. I think sustainability for primary care and virtual care is about workflow, and it's not the technology, but it's the adoption, right? But when we get into the marginalized populations, it's really back to those other determinants of health, and there's other reasons they're marginalized. And I think those have to be addressed almost with or at first, up front, prior to. I mean, healthcare is great, but it's not serving the greater need in the community, right? Or the other reasons that people are outside that tent.
Totally, and what you said about connectivity and, talking about how there's other kind of determinants, not just that limited technology or connectivity. You get into stuff like digital health literacy, their beliefs, people's beliefs about a specific like tool, whether it's harmful or not. And then you get into values and cultural norms and preferences to use these technologies. And we have to keep that in the back of our minds when we're talking about all these, because people have different backgrounds that are influenced by their social surroundings and context. So to be able to eventually create an integrative system, you have to consider the thoughts, perspectives of everyone involved, and keep in mind these digital and social determinants of health in whatever we do.
Co-create, co-design.
Mm-hmm.
I think what's encouraging about programs like this, and honestly, is there's a trap of and I think I heard it referenced on CBC, I can't remember the interview, but the social media performance. And I even myself feel guilty at times talking about this and wonderful ideas and concepts, but I'm like chomping at the bit. I just want to get going, right, and get started. And it's so frustrating and hard because we've done multiple grants and applications, and it's like, just give me funding for this. I just want to do it, right? And I think being able to talk about this as a community and network with others that are passionate about this, it inspires you to keep going, number one. But really look for areas where you can succeed. And like, again, Dr. Pepe said, I'm tired of trying to boil the ocean. Let's just work on getting physicians to code better, right? Maybe we'll get physicians to be impassioned about taking on patients that are marginalized. And look at Grenny's determinants of 6 influencers of change, right? I think I posted that before on LinkedIn. Making that which is difficult really what would inspire you, and hearing those patient stories inspires you. So part of what we're doing today is, I think, inspirational for others and motivate them to change either within their organization or put the pressure on the government for things like I referred to. Funding for virtual house calls, right, would be an important, not just because of my conflict of interest, and regardless of platform. This is a need, right, that we could serve. And how do we increase public awareness and pressure, right, to get that organizational or structural change within the system? And then also for the individuals to be inspired. And hearing those stories, hopefully that's what we can do today. Again, there's a lot of good work out there, grassroots, and we need mental health access. To be honest, right now, I find within my own practice, the funding for that, it's extremely difficult. The public system is backed up beyond belief and is in crisis survival mode. But to get cognitive therapy or behavior or one-on-one psychotherapy or good mental health counseling, if you don't have coverage, that's a challenge. I know there's a program, Together All, it used to be Big White Wall, became Together All. They're just pulling the plug on it. I'm like, seriously, no more funding, because it was a publicly accessed forum that people could go into and they could get some sort of connection with others, right?
I didn't know that. Big White Wall, they're pulling the funding. Wow.
It became Together All, and one of my patients just told me about this the other day, that doc, we just got notice it's not being funded anymore.
Wow.
Yeah. So there's bounce back, right? Which is it's okay. It's some telephone support. It's workbook style. But for the one-on-one stuff, that's tough. There's not a lot out there.
So when we're talking about virtual care, and you kind of mentioned how to make it fit within that publicly funded system, what is the role for kind of private organizations to kind of play a role in this? Like, keep in mind, if the government doesn't add funding to certain infrastructure to support this, the private sector may be able to swoop in. What are your thoughts on some of that? And, maybe a scenario where more work insurance may cover certain aspects of virtual care, whereas the public system doesn't.
Well, pre-COVID, that's exactly what happened. I mean, that's the reason that companies like Maple, Dialogue, Akira existed, is because their employers, and Teladoc, actually, I was one of the startup consultants, if you would, for helping Teladoc get into Canada. And so that was their business model. We go to employer, you have 1,000 people, we'll charge you $10 a month for access to our physicians when there's a problem. So COVID hit, and then the fee codes, of course, had to be generalized, and we are seeing Maple and all of those providers, private telemedicine providers, virtual care providers, be allowed to bill under those COVID codes. So I think post-COVID, you can already see those companies have aligned. They've applied for vendor verification. They've been accepted. I know Maple has for sure, and I think Dialogue has as well. That if there's a special rule for billing the OHIP codes virtually, they'll likely get the blessing and the go-ahead. So if physicians want to use that platform. So I think there's room for sure. From a primary care perspective, one of the concerns we've had is that, episodic versus continuity of care. There's that constant friction between the convenience of access and the quality of the outcome when it's somebody that knows you long-term, right?
Right.
And so the danger is going to be, as you see, the virtual walk-in, renewal, diabetic blood pressure, without any sort of long-term or episodic annual health review. What's your hemoglobin A1C and your cholesterol? The doc at the walk-in doesn't really care. You're here for your meds. Here you go, 90 days. Okay, you're good. You've got a doc? Yeah, okay, here you go. Right? Meanwhile, the patient has been never encountered, right, to review what's going on. So that, I would say, is the danger of having this as a almost two-tiered system. I say two-tiered, still publicly funded, but easily accessed. And I think ideally we want to funnel it into a primary care provider that has a relationship. And again, how do we make an incentive to look after those patients that are marginalized? Street medicine is a specialty unto itself, right? I mean, I'm a white guy in northern London that knows nothing about dealing with patients living on the street. And I'll be honest, and that's a whole other expertise I would like to learn. And Dr. Andrea Serratis done some amazing work here in London, the community health center she works at, just phenomenal work.
We got to get her on the podcast.
I was just going to say 100%. I'll do the intro. Yeah.
Awesome.
Yeah.
So with that being said, you presented both sides of the argument. You were very strong on saying, virtual care, but by no means as we are now is the silver bullet in of itself. So given all these nuances and contexts, what is your message for people in public health, healthcare, just a general citizen, in terms of virtual care and advancing it forward in an equitable way?
There's a lot in that one statement, I will say. Certainly, in advancing it forward, I think we have to keep our eyes on the ball of equity, right? And I've said before, we're doing a lot of great stuff and a lot of great work for the people inside the life raft. The 1,600 floating in the water still, we got to figure this out better, okay? And so I think awareness about that, certainly find out what's going on. We have people deprived of housing here in London, about estimates around 2,000, something like that. And if you figure on average $150 per visit to the Emerge, which is the only place they can get care if they even go, right? Think of the dollars that's using. And so this is where, again, thinking outside the box, outside of virtual care, putting nurses and docs in a bus and parking the bus where they might be, and regular rounds, right? With a knapsack walking down the street, and check out that final mission model, right? For Veterans Hospital. Really cool work, taking people who are social Sherpas, been through trauma themselves, recovered, and trained in navigating the social system, and building that trust with the people that are marginalized, literally going down under the bridge. And with the tablet, hey, you want to talk to the nurse? I can bring her online. Like, what a cool concept, that blend of technology, right? With reaching. Right. So I think that's kind of where I'd inspire people to go with this.
Thank you for listening to the Public Health Insight Podcast, your go-to space for informative conversations, inspiring community action. If you enjoy our content and would like to stay up to date, follow us on Instagram, Facebook, Twitter, and LinkedIn. To learn more about our community initiatives and how you can support us, visit our website at thepublichealthinsight.com. Join the PHI community, and let's make public health viral.